The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome back, TMD warriors. We are gathered here for the next episode of TMD Demystified, and my name is Tony Urbanic. Today's episode is entitled, "You Must Understand a Disease Before You Can Treat It Successfully." Kind of logical, right? If you're gonna treat a disease successfully, you must understand the disease first. I don't know anybody who'd want to argue that. Maybe some of you would. If you would, I'd be interested in talking to you. But the disease we're talking about on TMD Demystified is TMD, temporomandibular joint disorder, singular. To confront some of you out there, it is not a group of diseases. It is a singular disease, temporomandibular joint disorder, and the common denominator, spoiler alert, is inflammation in the joint, which drives each and every disparate symptom. That is why it is a disorder, because it does have a common denominator, which is inflammation within the temporomandibular joint. But getting back and making my point about the title, you must understand a disease before you can treat it successfully. And so I just gave you the key element of understanding TMD. And that was the discovery that I take credit for. It's hard to call it a discovery because all of this information has been in the scientific literature for the better part, if not in excess of 50 to 60 years, maybe even 70 years. So the information is there to look at. What I discovered was connecting the dots that had already been there to prove that all the disparate symptoms are driven by chronic inflammation within the temporomandibular joint. Now, I have beat on this concept many times on many different episodes, but the point of this episode is to compare and contrast it to what is actually being done or used in the general nature by dentists and dental schools trying to put a square peg through a round hole in treating TMD. At the very least is their efforts to treat TMD just by treating a particular symptom in that list of disparate symptoms and calling it a day. For example, I think the best example out there is the use of botulinum toxin A, or better known as Botox. Botox is almost a generic term now rather than botulinum toxin A, to paralyze muscles or a muscle. If the patient says it hurts there, you paralyze that muscle with botulinum toxin A, Botox. That muscle cannot contract. Therefore, the muscle will not pull on the bone where the nociceptors are, where the pain receptors are, where that muscle has origin insertion, and therefore the pain in that muscle derived from that muscle will go away. But what about the pain that goes over to this side of the face, or the pain that is associated with holding the neck still and neck pain, or tinnitus, subjective hearing loss, and vertigo, or earaches? Botulinum toxin A, Botox, does not address any of those that's injected into a particular muscle. Beyond that, botulinum toxin A is not is not qualified by the FDA as to be used for TMD. It is used off-label at your own risk if you're going to do this. And so if you damage a facial nerve, and it has happened multiple times, injecting botulinum toxin A in a place it shouldn't be, and you paralyze part of the face, which takes 3 to 4 months then to recover. In the meantime, you have paralysis of certain parts of the facial muscles. Say muscles of mastication is one thing. Facial muscles are driven by the seventh nerve, and if you in the vernacular bag the seventh nerve, you're going to have paralysis of the seventh nerve wherever it innervates. And you have now done that at your own risk because it is not FDA approved to be used for TMD. And so there are many downfalls and things that would prove that, although it's popular because the Botox people have a lot of money to spend on advertising and convincing an increasing number of dentists that they should add that to their line of work, injecting Botox into facial muscles, that really can cause some significant problems and significant damage to a patient that is not considered in the general nature of things. And then thirdly, a very well put together scientific article was published in the January issue of Journal of Oral Maxillofacial Surgery that scientifically, statistically shows that injecting botulinum toxin A into a masseter muscle, a jaw muscle, or using saline gives the same result. So a saline injection and a botulinum toxin A injection does the exact same thing, according to a very well substantiated article in the Journal of Oral and Maxillofacial Surgery, January 2023. So obviously, those who use Botox, doctors out there, dentists out there, really don't understand the disease. So let's go through this understanding of the disease a little bit deeper, because once you understand the disease, then it becomes very apparent the right kind of treatment to treat the disease, rather than the best example that I used was Botox, but there are many others. Dry needling is another. You can, if you are a physical therapist, or I've even heard of dentists starting to dry needle, put a dry needle, not injecting anything, just needling a muscle to the point where the muscle relaxes. And it is a physiologic phenomenon. I agree, it is a physiologic phenomenon. If you stick a needle enough times in a muscle, you will get the muscle to relax. And when the muscle relaxes, it doesn't pull on the bone and doesn't stimulate the nociceptors in the periosteum. And whatever pain is generated by that particular muscle will dissipate again. But what about the other disparate symptoms that are rapidly and associated with TMD? So what I found and can prove is that chronic inflammation within the temporomandibular joint drives all the symptoms. And the mechanism, here it is, here's the mechanism that occurs when you have temporomandibular joint inflammation that creates each and every symptom of the symptom list, which includes frequent and or recurring headache, earache, jaw pain, neck pain, ringing in the ears, tinnitus, subjective hearing loss, feeling of fullness in the ears, like you have water in the ear and it won't dissipate when you haven't been swimming, dizziness and or vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. And it has been shown in multiple ways, scientifically, academically, that if you decrease the chronic inflammation within the joint adequately, each and every one of those symptoms will dissipate and go away over time. They all don't go away simultaneously because the chronic inflammation works through two separate mechanisms to make it happen. But the primary mechanism is the following. If a joint, and this applies to any joint in the body, if you are a dentist, you were taught that this joint is unique, different, unlike any other joint in the body. That was a big lie. That was an untruth. That is not true. This joint operates just like the elbow, or just like the hip, or just like the knee, or just like the wrist. It has the same physiologic mechanisms like any other joint in the body. Of course, it's in a different place. Of course, it's shaped a little differently. It's attached to the jaw on both sides, unlike other joints, but the hips are similar in that the joint is attached to the pelvis and operate independently the legs, while this joint is attached to the skull and dependently operate a single bone. But the point is two joints operating in unison one way or another. But this joint operates like any other joint in the body, and here's the physiologic operation that has been well known in the literature for better than 50 years. It is part of the autonomic nervous system coordination of muscles, whether they be physiologic or non-physiologic. But under the autonomic nervous system, the sympathetic portion of the autonomic nervous system, which is the fight or flight portion of the autonomic nervous system, which regulates fight or flight, whether it be something exterior to the body. Someone attacking you with a knife would stimulate the sympathetic portion of the autonomic nervous system to give you the fight or flight response, to battle it or to remove yourself from the situation. That will be an external stimulation, but the body also has internal stimulations that will stimulate the fight or flight part of the autonomic nervous system, the sympathetic portion. And one of the internal stimulants that will stimulate the fight or flight part of the autonomic nervous system is chronic inflammation. Inflammation that goes beyond the normal healing type of cells with inflammation. Don't forget, I'm a cell biologist by training and an anatomist, cell biologist, anatomist by training, and familiar with this. The chronic inflammation, which develops when normal inflammation does not go on to healing, and the cell types change somewhat, and the motion and the development of cells are different under chronic inflammation. But under chronic inflammation, it stimulates the sympathetic portion of the autonomic nervous system. And when this joint becomes inflamed, a signal is sent through the sympathetic portion to the brain, specifically the brain stem, that announces it's inflamed. When that signal arrives in the brain stem acknowledges it, modulates it, and sends back a signal, says, I understand you are inflamed, I'm going to help you heal, and sends a signal to all the muscles that move the jaw joints to tighten up, to contract, don't move the joint. That's how you help a joint to heal. And actually, tennis elbow and TMD are the same disease. Tennis elbow has the exact same physiologic mechanism working with it. When the lateral epicondyle of the elbow is chronically inflamed because of too much tennis or too much repetitive motion of the forearm, a signal is sent to the brain stem, says, I'm inflamed. The brain stem says, I see you're inflamed. Don't move the elbow, and the signal goes down, not to the elbow, to the muscles that move the elbow to tighten up, contract. When they get that signal, they tighten up, contract wherever those muscles are attached to the bone of the forearm, the ulnar radius, and they pull on the periosteum where the nociceptors are located, the pain receptors are located. It stimulates pain, and the pain then goes back and registered in the brain and in the brain stem as pain. Well, that's exact same mechanism occurs with the temporomandibular joint, and the muscles get tight and the muscles pull on the bone, not always at the same time, not always on the same day, not always on the same side. And that is why these pains move around on the face and can occur in any of the muscles that are associated with mastication. There are six major muscles, including the mylohyoid, masseter, temporalis, medial and external pterygoids. And those muscles, when they get signals to get tight, they will pull on the bone and stimulate the nociceptors in the periosteum, and the patient will elicit pain in that particular area. So you can see, going back to the example of Botox, how stupid it is to actually address just a symptom on one particular area when those signals can travel wherever they want to end up and on the muscles of mastication, and then factor in all of the potential side effects and risks that you entail by using Botox just to perform a action on one particular muscle. You can see how actually dumb that is. If you can decrease inflammation within the joint and handle all of the potential pains of headache and jaw pain, upper back and shoulder pain, arm, hand, finger tingling and numbness, which is generated by the neck muscles when they get stimulated, squeezing the brachial plexus, when just by decreasing inflammation in the joint.